Welcome to the Fit Strong Women Over 50 podcast, episode number 161. Hi, I'm Chris. Thank you for joining us today.
And I'm Jill. Chris and I are your hosts for this podcast and the founders of the Becoming Ellie community.
In case you're wondering, we decided to name our community Becoming Ellie because Ellie was the Norse goddess of aging who beat Thor in a wrestling match. Jill and I thought, hey, we want to be like Ellie, fit and strong as we age.
Yes. You can find out more about the Becoming Ellie community and this podcast at becomingellie.com. And Ellie is spelled E-L-L-I. Be sure to sign up for our newsletter while you're there. That way you'll know about new episodes and anything else that's new with us.
Hey, we have a shout out today. Angel was talking about episode number 148, which was titled Avoiding Menopause Weight Gain with Amy Wilson. And she said, love this podcast. And I took notes as I want to start eating well again. It's hard to take in, so I might have to listen to it a couple of times.
Yeah, I know what you mean about that. But that's great. Thanks, Angel. Today, we're talking about menopause, weight loss, and other topics with Dr. Makaila Woods. She is a functional medicine doctor with lots of credentials. She knows what she's talking about. Let's go to the podcast. Dr. Makaila Woods is a certified practitioner for the Institute for Functional Medicine and has a double board certification with the American Board of Obesity Medicine and American Board of Obstetrics and Gynecology.
She is a native of Wichita, Kansas. She earned her bachelor's degree with cum laude distinction from Wichita State University. She completed her doctorate of medicine and master's in public health degrees from the University of Kansas School of Medicine. Dr. Woods completed her residency in obstetrics and gynecology at the University of Missouri, Kansas City.
Dr. Woods is the founder of Dr. Woods Wellness, established in 2013. When not working in the office, Dr. Woods enjoys singing, especially gospel music. She has been a choir director throughout the years and a wedding singer for many of her family and friends. Spending time with her wonderfully supportive husband, daughter, and son are her most treasured moments.
Welcome, Makaila. It's wonderful to have you join us.
Thank you so much for having me, Jill and Chris.
Great. We're looking forward to this. Let's start with how you ended up getting into functional medicine and weight loss from gynecology and obstetrics.
Absolutely. I'm going to give you the short version.
Okay.
All right. So I got into obstetrics and gynecology actually from a very interesting 8th grade biology class. I had this old former military guy named Mr. Fluke, and he made science so fun. When we got to the life sciences and reproduction, just a thought came to my mind, wouldn't it be neat to deliver babies? And so I just pursued that idea from 8th grade. Fast forward to 2011, I was a year out from having my second kid. I was in a very busy OB-GYN practice. I was seeing probably 30, 40 people a day, ladies, and being told I needed to see, and being told I needed to see more. So at that point, I was a little bit disillusioned in my job. I had gotten up to 240 pounds. So I knew I needed to do something personally as far as my health and also professionally. So my first step outside of the regular obstetrics and gynecology practice was to learn about weight loss. And I got board certified in obesity medicine, started offering some services there. And the very first program I offered, ladies, was 5 shakes a day. So everything I offer my patients, I've tried it, most everything. So I did 5 shakes a day. I lost about 20 pounds, but I was horribly constipated. So I wouldn't recommend that. But anyway, that was sort of like the impetus to kind of get things going. Then I left that group, thank goodness, started my own practice in 2012. And I started to learn about bioidentical hormones. And it actually began with conversation from patients telling me how great they were feeling. I started taking some coursework. I got a certification in bioidentical hormone replacement therapy and realized even as a board certified OB-GYN, I really didn't know anything about bioidentical hormones. And from there, going to conferences with a friend I met, a physician in California. She mentioned functional medicine back in like 2013. I was like, I've never even heard of that. What is it? And I learned that it was about root causes, natural solutions, immediately started taking coursework, got certified with IFM, the Institute for Functional Medicine. But I really feel like, from the very first course, like my mind was blown and I was like, this is what I've been missing. And really, ladies, I almost got upset because I was like, why has no one told me about these things? So now, fast forward 10, 11 years later, functional medicine is the umbrella under which I do all the other things, which is hormone replacement, weight loss, helping people with thyroid issues, inflammation, et cetera.
Can you tell us what functional medicine is? And you just touched on it, but how does that actually differ from standard medicine? Is this like when you're saying, I really would like to know why I have this, not just what medicine should I be taking? Are you who we go see?
Absolutely. And so, Jill, the way I'll give you an analogy of like functional medicine compared to traditional medicine. Think about a picture of an iceberg and you see the tip of the iceberg above the surface of the water. That is analogous to traditional medicine. And traditional medicine is often asking the question, what do you have? What is the diagnosis? Because of course, all of their compensation is tied into billing and coding and diagnosis. Underneath the surface of that iceberg, if you can imagine, there's a lot more, first of all, and really the bulk of that iceberg is below the surface. And I think about functional medicine as being below the surface, the idea that we want to dig deeper, the idea that we want to ask the question why and not just what. And to give you a more practical example, let's take a diagnosis like IBS, irritable bowel syndrome. First of all, that is just a label. It means you might have diarrhea, you may have constipation, but it doesn't really tell us why you're having that. And so the traditional approach is I'm going to give you a medication to stop diarrhea or maybe to stop constipation. Whereas from the functional medicine perspective, we want to take a deeper dive into the gut. We want to look for overgrowth of bacteria. We want to assess whether or not you have proper digestion, proper acid, et cetera, et cetera. So that's just one example of the difference. And I'll say this too, a big difference between functional medicine and traditional medicine is traditional medicine is very siloed, if you will. Like if you have one issue, you have to see the endocrinologist or the neurologist or the cardiologist or the gynecologist, you know what I mean? Whereas in functional medicine, we really try to go back to the old school way of treating you as an entire person. So it's kind of like a systems biology approach is the terminology for that. And so we really recognize, and another picture that we often see to depict functional medicine is a tree. And so it's this idea that if you start to treat the roots and let that be the analogy of your body, you can see an improvement and a manifestation in a lot of different areas. So like inflammation, for example, if you start to treat inflammation, your energy will be better, your brain fog will be better, you'll start losing weight, you'll see a myriad of improvements just from dealing with one root cause issue. So that's kind of functional medicine in a nutshell.
Okay, great. Thank you.
If we wanted to find a functional medicine doctor, how would we go about finding that? Do we see a functional medicine doctor at the same time as a primary care doctor?
That is a great question. I really like to think of a functional medicine doctor as more of a specialist. So you're going to work in tandem with your primary care doctor. You always need your primary care doctor. Another thing that is important to note is that most functional medicine doctors do not take insurance. So you want to keep your primary care doctor for those things that fall under insurance. Again, the way that I describe that is that, unfortunately, the traditional medical world is really about treating sickness versus treating or covering wellness and prevention. And so again, consider us a different specialty. The place that I would look, and this is where I got my certification, the Institute for Functional Medicine, and their website is ifm.org. So, IF as in functional medicine, m.org. That's where you can find a functional medicine provider in your area.
You just mentioned that you're certified in bioidentical hormone replacement therapy. Can you explain what that is? What does that mean?
Absolutely. So when we say bioidentical hormones, we mean that it has the same chemical structure as the hormones that your body naturally produces. So typically the men and women that I see for bioidentical hormone replacement therapy, let's talk about women more specifically, they're going through the transition. So they're heading toward menopause. Technically, menopause is defined as 1 year without a period. The average age of menopause is 51. For women who don't have a uterus anymore, the way you also know that you're approaching menopause is you start getting those symptoms like hot flashes, night sweats, vaginal dryness. Those types of things can key you in that you're approaching menopause. And so the bioidentical hormone replacement therapy is the idea we're giving back to the body what's missing, and we can alleviate those symptoms.
When I first heard about bioidentical hormones, there was something called Premarin that I don't think is bioidentical. Can you talk about that a little bit? Do you know what I'm talking about?
Absolutely. Yeah. So Premarin is the way we pronounce it. And that is a synthetic estrogen. And that Premarin comes from pregnant mare's urine. So it comes from the pregnant horses, basically, pregnant horses' urine. And that is a combination of a multitude of synthetic estrogens. Some of them haven't even really been studied. And I'll give a little bit of backstory about bioidentical hormones, because I imagine when people hear hormone replacement in general, there is often a fear about cancer. So let me just kind of dive into that a little bit.
Good.
A little bit of a backstory. Yeah. So there was a big study that came out in 2002 called the Women's Health Initiative. And so I was really kind of on the forefront when all of that happened because I was an OB-GYN resident. And so prior to the Women's Health Initiative study coming out in 2002, it was the understanding of all obstetrician gynecologists that when a woman starts having menopausal symptoms, you put her on hormone replacement, such as a Premarin or a Prim Pro, and she stays on it for the rest of her life. We thought it was good for that. We thought it was also helpful for prevention of heart disease, et cetera. This study came out. It was the largest randomized, double-blind, placebo-controlled clinical trial, which is considered the gold standard of research studies. And they randomized women into a Premarin-only group, which is a synthetic estrogen, or a Prim Pro group, which is synthetic estrogen and synthetic progesterone, technically called a progestin. What happened is they stopped the study early because they saw an increased risk of breast cancer, heart attack, and stroke. So then all over, the news, et cetera, was the headline that hormones cause cancer. And so I just imagined every primary care doctor was literally just ripping up prescriptions for hormone replacement, just kind of snatching it out of the hands of women. And at that time, only the gynecologists were still prescribing hormones because we did have observational data before that. And then, 20 plus years later, we have a different understanding. So let me point out some of the shortcomings of that study. So first of all, the average age of women in that study was about 62. Now, I just told you a moment ago that the average age of menopause is 51. So in the real world, no doctor starts a patient on hormones for the very first time in their 60s. That would be very rare to happen. And what we've learned about estrogen is that it is really time dependent in a way. So if you give a woman estrogen early enough before she has developed any type of plaque or buildup in her arteries, it can be helpful and help to prevent heart disease. And you may have heard the studies that heart disease risk goes up in women when they go through menopause. And the reason is because their estrogen is actually declining. And so if you give the estrogen early enough, it can be preventive. But if you give estrogen after plaque has developed in the arteries, then it could potentially disrupt that plaque, which could be a heart attack, on the heart, or a stroke on the brain if you disrupt those blood vessels. So that's one thing as far as that is concerned. Another thing that they found in that study as they started to tease out the data, it was actually the group of women who got the Prim Pro, synthetic estrogen plus the synthetic progestin, that had the risk of heart attack, stroke, and breast cancer. So it wasn't even the synthetic estrogen. And when you looked at the group in the synthetic estrogen group, the risk of breast cancer was actually slightly lower. It wasn't statistically significant, but it was a little bit lower, which is another interesting thing. How in the world could giving estrogen reduce the risk of breast cancer? Because estrogen has anti-inflammatory impacts and other things like that. Let me also say this too as a caveat. Obviously, if someone has a breast cancer that is estrogen receptor positive or progesterone receptor positive, then of course they shouldn't be on those hormones, but it doesn't necessarily mean that the hormones cause cancer. So again, it's been 20 plus years trying to unravel all of this data. And even some of the top, the National American Menopause Society and some of these governing bodies have now put out other statements, kind of dialing back and retracting some of that information. Another shortcoming to that study is that they didn't look at bioidentical hormones at all. They only looked at the synthetic, whereas the data that we had on bioidentical hormones was actually pretty good. And there's a difference between bioidentical and synthetic, and I can jump into that as well in a moment. But that kind of gives you a little bit of that nutshell about that controversy.
Thanks for explaining that, because I think there is some confusion about folks that are just starting, perimenopause, to try to understand what's the difference between synthetic and bioidentical and what about the stories. So thanks for that explanation. I appreciate it.
And is at this point, would all OBGYNs or anyone prescribe bioidentical, or would they be still prescribing the synthetic?
So I would hope that most of my OB-GYN colleagues are prescribing bioidentical. And I do see a trend that more of them are. And so there are commercially prepared now bioidentical hormones more than there was in the past. Because again, when I was in residency, it was kind of Premarin and Prempro, that's all we knew. Like those reps would come and buy us books and take us to the spa and, really, butter us up, to prescribe their hormones. Like I really didn't even know of anymore when I was a resident. That's how much of the market that one company had. But now, since the Women's Health Initiative, there are a lot of commercially prepared bioidentical hormones. And I would hope that more of my colleagues are using those. What I use is compounded. And so that's a little bit different. So it's prepared by compounding pharmacies. It allows us a little bit more leeway as far as the dosing is concerned, versus just the standard dosing on the commercially prepared. And then it also allows us different modalities that you might not get, say, from your regular pharmacy.
If someone is experiencing, those symptoms, do you have a test that you give them, a blood test or urine test? How do you know how much to give them and what kind of stuff?
Absolutely. So when you come to a hormone specialist or a bioidentical hormone specialist, we're definitely going to check lab work. So we can check your estrogen, your testosterone, your progesterone levels. The traditional OB-GYN, they're really not into checking the labs. They're more so going to treat you based on your symptoms only, which I think that's, valid in some cases. But again, the functional medicine approach, we want to take a full comprehensive picture. And so I like to take a look at the labs because I also like to see, once we start our therapy, I want to see what the improvements are. So I like to do blood work. Some practitioners may do saliva. And there's also even a urine test as well. So there's different modalities. But I really like to stick with the traditional in the sense of checking blood work.
You obviously help women who are approaching menopause or going through it. Are there ways to improve menopause, the effects of that besides hormones?
Absolutely. One of the first things I talk about as it relates to this is there are certain menopause pretenders that you need to be aware of. And so sometimes even younger women, they're having symptoms and they're thinking they're going through menopause, but it's really not that. Or you may be approaching that age and there may be some behaviors or lifestyle factors that are exacerbating those menopausal symptoms. One of the big menopause pretenders is sugar. Okay. Sugar, first of all, it's inflammatory. So from the functional medicine standpoint, we really try to caution you. And then sugar also, let's think about it this way. And this is probably the way that a lot of women get it. Having that glass of wine at night, right? So on one hand, they're thinking, okay, this is going to relax me. I'm going to sleep better. But what happens very shortly after taking in that wine, your blood sugar goes up. Then a little while later in the middle of the night, your blood sugar starts to crash. And then your body has to compensate. Cortisol is kicked off. Your body is trying to bring the blood sugar back up. You can start sweating. You can wake up. So sometimes when you're waking up in the middle of the night, you're having flashes in the middle of the night. It's not necessarily your hormones in that sense. It's the hormones of like insulin and cortisol. So alcohol is a menopause pretender. So if you want to do some of the things you can do again to alleviate menopause naturally is to beware blood sugar. And then I also talk about alcohol separately. Those kind of go hand in hand. Another thing that we found is that women who exercise regularly, and I know you guys are all about that, that can definitely help alleviate some of those menopausal symptoms. And then there are some natural herbs and things like that that could be helpful, such as black cohosh, chaste tree, magnesium, dim. These are some of the things that can be helpful from like an herbal standpoint to help. And then there are also prescription medications that can help somewhat with hot flashes and night sweats. They're typically in the category of an antidepressant, but they can sometimes help women, especially if they have a true contraindication to estrogen. Say someone who's actively, being treated with breast cancer, or even if they have a family history and just a concern. And so, one of the things that I talk to my patients about all the time, Jill and Chris, is that, I believe in hormones, but I don't push it. And so if someone says that they're fearful of it, then I don't want to push that. There's other things that we can do to help, women feel better through that transition.
What about if a woman over 50 comes to you and says they want to lose weight? They just can't seem to lose the weight around their middle. And, first of all, is that caused by menopause? And how do you help them?
Absolutely. So very commonly, I have women come in and they literally, whether I'm seeing them in person or on virtual, they just kind of grab that midsection and say, I don't know what happened here. This wasn't here, a year ago, 18 months ago. So belly fat around the middle is a very common occurrence in women going through menopause, perimenopause. Let me define perimenopause also. Perimenopause is just the years before you go into the full out menopause. And so it can happen in the early to mid 40s and also extend a little bit into the 50s. So women can be experiencing symptoms for, a decade, really. So the belly fat, one of the root causes of that is hormonally related. And so when we think about estrogen and progesterone, both of them are declining in the body, but though both of estrogen and progesterone, estrogen is usually higher, they're both declining, but progesterone declines faster. So in essence, you get a wider gap or you become in an estrogen dominant state. And estrogen is traditionally a fat storing hormone. So you think about women in pregnancy, estrogen skyrockets and you're gaining weight and you're, storing that fat to, feed that baby, et cetera. So you're not trying to feed a baby in your 50s, of course. And again, it's relatively speaking. So again, estrogen is low, but in comparison to progesterone, the estrogen is higher. So become estrogen dominant. That is a very important factor as it relates to belly fat. Also testosterone, which we haven't talked about yet, which is a very important hormone that is often ignored, especially amongst the traditional OB-GYNs for women who are in this transition period. But your ovaries produce estrogen, progesterone, and testosterone. And so all of those hormones are declining. If your testosterone is declining, that is also working against you as far as your metabolic profile, because testosterone helps you build muscle mass over time so that you can burn fat more efficiently. So kind of think back if any of you have ever competed with a guy as far as weight loss and they always lose weight faster and it's just not fair, right? Because they have more muscle mass to start with. That's part of it. They can burn it faster because they have more muscle mass to start with. So
another good reason to build muscle.
Yes, absolutely.
So there are lots of new weight loss treatments, I gather. Can you tell us about some of them and what you recommend or what your thoughts are? And what role does medication have with weight loss?
Absolutely. So the big one now are the injectables. The generic name is semaglutide. It goes under the brand name Ozempic, and that was initially branded for diabetes. It also goes under the brand name Wegovy, which is the same medication, but branded for weight loss. And then one of the other newer ones, generic name is tirzepatide, goes under the brand name Mounjaro. So these are weekly injectable medications. They're called GLP-1 agonists. GLP-1 is something that your body naturally produces, but these medications really amp up the effect. Think of it that way. Three main ways in which they work. One, they slow down gastric emptying, so you feel fuller faster. So you just literally cannot eat as much food. Number two, they reduce a hunger hormone called ghrelin. So it helps with cravings. And then thirdly, it literally helps your body burn stored fat. So it can be quite effective. There are definitely a lot of horror stories that you hear about these medications. And I do offer them in my practice. I was not early on the bandwagon because I really wanted to see how people were doing. And I wanted to see how to take a little bit of a different and more of a functional medicine approach. And so the first thing that we do differently from the functional medicine perspective is that we start very, very low. So our idea is that we don't want to kind of just slam you with a lot of this medication. We want to start very low. We call it micro dosing initially. Our other goal from the functional medicine standpoint is that we don't want to get any side effects are very minimal. Common side effects because of that slowed gastric emptying can be nausea, constipation, things like that. So we start very low. We monitor for those symptoms. And my approach is if you're vomiting or if you're horribly constipated, then you may not need to be on this medication at all. And we definitely don't need to go up. Like I remember one of the horror stories, Jill, that I read about is this lady said she threw up every day for a year.
Oh my gosh.
Well, first of all, why did you stay on it for a year? Right. She did lose a lot of weight, but that just doesn't make any sense. And so right. So you kind of set yourself up, I think, for further complication if you just try to push through. And so I do use a compounded version of that. And as I stated early on, compounded pharmacies are able to give us different dosing so we can microdose and adjust it. The other things that are super important if you're going to do this medication, and I would say that whether you're getting it from your traditional doctor or if you're going to a doctor who offers it compounded, you really need to take a comprehensive approach. So you have to exercise regularly. You have to do strength training. One of the other potential risks is muscle loss. And so one thing I want to point out is that regardless of what modality you use to lose weight, muscle loss is very common, especially if you're losing weight rather rapidly or just a significant amount of weight. And so the way that you counter that is you've got to do some strength training. And then the other thing that's important is just monitoring what you eat, because unfortunately, what I hear in the traditional world is that people get these medications and they get absolutely no guidance on what to eat, how to eat, nothing. They're just given the prescription. And so, yeah, you'll eat less. But if you're just eating less of the same junk, as soon as you come off of it, you're going to go back to eating more of that junk and that weight is going to come back. And so, oftentimes, and this has been documented, in research, if you look at data, and this is even prior to the GLP-1s, but if you look at data on how people lose weight, whether it's medication, diet and exercise, even surgery, over time, the first part of that time after the procedure or whatever intervention, people lose weight rather quickly. And then over time, everybody starts gaining weight back. So the curve goes up. In some ways, it's easier to lose weight than it is to keep the weight off. And so the things that we do in conjunction with that medication is really to help people put in the proper habits so that they can have success when they come off of it. My other approach to it, Jill, is that it's meant to be a tool for a period of time, not a forever medication. So for those who are taking it, say for diabetes, the brand Ozempic, that may be the intention that they're going to use that forever. That's not my intention for my patients. It's a tool for a period of time. And so we really try to train them up and coach them. We have an integrative nutrition coach in our practice as well to help them make all the healthy changes that are necessary to lose that weight. But let me say this too. I have seen great weight loss success without prescription medications. And so optimizing hormones is a wonderful way to help people lose weight, whether it's optimizing the estrogen, progesterone, testosterone, optimizing thyroid. I've seen people lose weight rather rapidly and successfully. And so I try to remind people of that because I think sometimes now, Jill and Chris, people are kind of having a little bit of FOMO, fear of missing out, as it relates to the injectable. Like everybody thinks now that's the only way to lose weight. And that's not true either. But it can be used safely. I do believe that.
So you can still lose weight without using medication.
Yes,
get
absolutely.
Your hormones in balance.
And do exercise and eat right.
Yeah. And of course, yeah, I mean, it always start with the basics, right? So that's going to be looking at your nutrition. It's going to be looking at your physical activity. And I think when people, by the time they come to me, oftentimes they've tried a lot of things. They're frustrated. And so for some people, they've tried the diet and the exercise and they're just still not getting anywhere. And that's when I know, okay, it's probably something hormonal that we need to dial in for you so that we can shift your metabolism in a positive way for you. But always start with, nutrition, movement, things like that. But I also recognize, even a lot of people that I've seen who are severely overweight, they'll tell me that they don't eat much or they just eat one meal a day. And I totally believe that because their metabolism is crashed, like they're not even hungry anymore. So there's really a lot of work to be done, kind of unraveling the damage, that had occurred in those bodies probably for decades.
When you're trying to help your clients with food choices, what type of food advice do you offer to clients? Is it a combination of what to eat and how to eat and when to eat? And can you give us some examples of what you suggest?
So a couple of things that I like to hone in on. First of all, I don't like to do calorie counting at all. It's more about food choices for me. And so I really like a paleo type meal plan versus keto. I'll kind of use those two because those are very popular. From the functional medicine perspective, because keto allows a lot of dairy is known to be inflammatory. And I tell people also, some people who have like supposedly seasonal allergies, but they're all year long, I really challenge those people to look at whether dairy is a culprit of that, because dairy also increases mucus secretions. And so some people who have a postnasal drip and they're running some of that is just dairy. So I am not a big proponent of keto for that reason, though there's a lot of great data about the benefits of keto. I would say try to do a clean keto meal plan versus a dirty keto. So to me, dirty keto is like a lot of cheese and, things like that.
A lot of bacon in keto.
Yeah. See, that's dirty keto if you eat bacon every day, things like that. I like some bacon every now and again, don't get me wrong. Whereas I like paleo because paleo is also low carb. So keto and paleo are both low carb. And I think the evidence is pretty clear that a low carb plan beats out, say, a low fat plan, for example. I think back in the 80s and 90s, it was all about low fat. So I think we're very clear that low carb is the way to go. And low carb was the Atkins diet. And so these newer ones are just kind of sexy new versions of that. It's kind of how I see it. But paleo is no grains and no dairy, but you can have meats, you can have fruits and vegetables, which really on the keto, because the carb recommendation is, I think, like 5%. So you could barely have a piece of fruit on keto. Whereas on paleo, you can have the fruit. And so you have more diversity in your food choices as far as paleo. And I think that's more easily sustainable because I like to really talk about not diets, but like what is the meal plan that you can follow and that you can follow most of the time. So that's one. Another thing that I focus on too, Chris, is getting in enough protein. I think that's important. And I know some of the, recommendations have changed. I still kind of stick with the idea about half your body weight in grams of protein, up to maybe 90 to 100. And so grams. And I think most people, most women are deficient in protein. And then back to our conversation about building muscle mass, you need to get protein on board. And then why is protein important? In other aspects, it helps to stabilize your blood sugar so that you're not getting as hungry. And that's also going to be in your favor as far as burning fat. So protein plays a great role as far as metabolism, weight loss, satiety, building muscle. So those are probably the two big things. And then I'll say too, I think intermittent fasting is another great strategy to use as well. Common way to intermittent fast is sort of the 8/16. Where you eat in an 8-hour window and you fast for 16 hours. So, you might eat from 11 a.m. to 7 p.m. or noon to 8, and then you fast the rest of the time. I think that's another great way, especially if someone is just stepping into kind of changing habits. That's an easy one. I even had a friend of mine who she didn't really change her diet. She just did intermittent fasting, started walking, and started losing weight rather quickly.
What about people who do the more extended fasting? What's your thought on that?
Yeah, I think that all of those types of fastings can be helpful. I do think it's important to cycle it, so with intermittent fasting, there's different ones. So again, 8-16 is probably the most popular one, but there are other versions where you may do a whole 24-hour fast, maybe a couple of days a week or something like that. I think any of those are helpful. What's interesting about fasting is that there's sort of a line. So on one side of the line, the benefit of fasting is that you're able to burn stored fat. You're able to rest your digestive tract. There's benefits there. The other line, though, if you go too far, is that if your body goes into actual starvation mode, then your body wants to store fat instead of burning it. So that's why either you cycle, say a 24-hour, or you do a little small window every day. I think those are probably the most beneficial for those who are looking to lose weight. I'll say that too.
So women who are very active, does that change your recommendation at all?
As far as intermittent fasting or foods in general?
Food, intermittent fasting, yeah.
Yeah, it can, because ultimately I want that woman to not put aside her exercise in order to fast. So say, for example, if someone does a very strenuous morning workout, then maybe they can't intermittent fast. Like if they need a little pre-workout apple, something or other, I think that's completely fine. And the other thing with intermittent fasting is that they've also shown that even if you just fast for 12 hours instead of 16, like you can still get a benefit. So in those instances, it may be a matter of modifying that.
Okay. So 12 hours is basically eat your dinner and then just don't eat until you have breakfast.
That's right. Yeah. And even that can be beneficial. I think that, in our society nowadays, there's so much snacking and, there's so much excessive eating, the mindless eating it used to be in front of the TV. Now it's in front of, the phone screen, et cetera. So yeah, I think just cutting it off at some point or some interval can be beneficial for a lot of people because we just don't realize how much we just snack needlessly.
Right. On your website, I saw you have a program that you call the E3 methodology.
Yeah.
Can you tell us what that is and what are the different steps or components of it?
Yeah, absolutely. And so I kind of coined that because it's really my approach to helping women and men really take charge of their health. And so the first thing I like to do is just enlighten you, like what is going on with my body. That's why we do a comprehensive lab panel so you can see in black and white or in full color exactly what's going on. Because, a lot of my people, and I'm sure, your audience as well, I call them the true health seekers. If you're listening to podcasts, if you're doing your research, you're a true health seeker. But at the same time, sometimes the shortfall of the true health seeker, they're using the HAP method of trying to get healthy, hoping and a praying. Now, I believe in prayer, but I say that kind of jokingly, in the sense that, you're just sort of reaching and grabbing for a lot of things. You saw this thing on the YouTube and you heard this expert say this and your cousin said, try that. And so you just have a lot of random things that you're doing, trying to get healthy, hoping and praying. And so what I like to do is, first of all, let's just enlighten you so you know what's going on with you specifically. And then the next E is to empower. So you're going to feel empowered because hey, this is what's happening in my body. I'm not losing my mind. It's not all in my head. There's really something going on. And then that third E is really to get you energized, because once you're enlightened and empowered, then we want you to be energized to make change. And then we also want you to be energized to help other people. And certainly when women get better, healthier, their households are getting healthier, you start getting, the whole community gets better. So that's really the idea behind that.
It's like the ripple effect. Yes.
Yes, absolutely. Absolutely.
So your practice is you're in?
Oh, yeah. So I'm from Wichita, but I'm located in Lee Summit, Missouri, which is a suburb of Kansas City, Missouri. But I'm licensed in Missouri, Kansas, and California.
Okay. But you see patients in person. You're not a virtual.
I'm really hybrid. Yeah, I'm hybrid. Yeah. So usually my initial visit is virtual because we spend 90 minutes on that first visit. So you can do that from the comfort of your own home, but we take a real deep dive. We take a look at that comprehensive functional health report, which is the lab panel. And then some patients come in if they're getting certain procedures, like if they're doing hormone, we do injections, we do pellets, we do all types. For weight loss people, they may come in and get a body comp. So some people come in, and then a lot of people, I do just my consults virtually.
So, Dr. Woods, if our listeners would like to follow you online, where would they go?
So my office website is drwoodswellness.com. And then also I have a free Facebook community called the Natural Hormone Fix. So we talk about hormones from the functional medicine perspective. And then also if they want to get my free report, which is the 3 secrets to hormone balance every woman should know, it is drwoodswellness.com/guide, GUIDE.
Oh, good. And we'll make sure that we have those URLs on our show notes for your website and also for the guide and your group. So wonderful. Thank you so much for sharing all this wonderful information with us and with our listeners. Really appreciate it.
My pleasure.
Yes, I feel like we could have kept you here for quite a while, but thank you for your time.
Mine's your part too. No. Thank you, ladies.
Thank you. All right. Bye-bye.
Bye.
Bye.
Dr. Woods sure has some great ideas. I love what she had to say about the bioidentical hormones, and I really appreciate that she spelled out the difference between synthetics and compounded and, the not over the counter.
Yeah, I did not know that they now have like prescription bioidentical hormones, but they're not compounded. I didn't even know they had that.
Well, it's amazing. Things keep changing. And if you're not looking into it or hearing about it, how would you know? It's
right.
It's hard to understand all of that. But
yeah. Well, it's good to at least have the information. So it's something to discuss with your own doctor.
Sure.
Speaking about that, I liked what she was saying about using weight loss drugs like Ozempic and using the microdoses. And you hear a lot of negative things about medications, but they also work really well for people. It sounded like she had a really good way to use medication like that, and her goal was not to keep you on it forever.
The other thing I liked that she said was about pretender behaviors, and I think she was talking about different things that different ways you feel and you think it's your hormones, but it's actually a relationship with sugar and alcohol and how your body's processing that now, and the inflammation with the insulin and the cortisol. And I guess those are hormones, but it's different things than menopause that might be causing the problem.
And that was a good point. There are other hormones in our body besides estrogen, testosterone, and progesterone.
Right.
The other ones can be doing whatever to you too.
Oh yeah. That cortisol, man, the wake up in the middle of the night, I fought that for an awful long time until I started really checking and finding out what's going on with me. And, it's important to know because it makes you feel terrible if you don't get a good night's sleep.
Right. The other thing is she is another person saying we need to get protein into our diet. I think when you keep hearing the same message, it's wise to pay attention. It's like, pay attention here, Jill.
Right. When she was talking about keto versus paleo, the dairy, all those things about eating clean is good, maybe low carb, but not off the deep end and eliminating vegetables. I guess it's more moderate than some of the other choices. You know what I mean? Strength training, exercise. I mean, she just ticked all the boxes, didn't she?
Yes, indeed. It was nice to actually hear a physician talking about some of these things because there's a lot of science behind what we keep talking about. So it was good to have someone who was able to explain it. Really, she was very good at explaining what was going on.
Yeah, very articulate. For our listeners, please let Jill and me know if you have some thoughts on what Dr. Woods had to say or any experiences that you may want to share about hormone replacement therapy or your weight loss journey. Please contact us.
Yeah, you can leave us a message at becomingellie.com, or you can find us as Becoming Ellie on Facebook, Instagram, X, Pinterest, YouTube, and LinkedIn.
And if you don't already belong, be sure to join our private Facebook group, Becoming Ellie.
Yes, it would be great to have you join us.
It was wonderful talking with you today, Jill. I'm looking forward to our next episode of the Fit Strong Women Over 50 podcast.
I am too. See you next time. Bye-bye.
Bye.